So thank you once again, panel. These presentations were really spot on and, again, inspirational. So thank you, Maricel, Justine, Rishi, and Mimi. Really good afternoon panel. So let's open it up for discussion. We have about a little more than half hour or so. We'll begin with the roundtable member questions first. And once again, I'm going to ask the community members, public members, to please ask questions. We'll be happy to recognize you. Rob?
Is it on? Okay, good. I think it is. Rob Logan, National Library of Medicine. After the social unrest in Ferguson, Missouri, 2 summers ago, I think a lot of you remember that episode, after Hurricane Katrina leveled New Orleans, after a tornado leveled the entire town of Joplin, Missouri, several years ago, and numerous other examples of tornadoes and floods all across the United States, the trusted source for the population that lived there, and literally the trusted place, the, quote, safe haven, not my words, theirs, were public libraries. And as good psychologists like Steve Rush would say, it was operant. There was no outreach. There was no effort to get people there. It just happened. And by the way, in New Orleans and Joplin and 2 or 3 other examples, people went to damaged buildings, okay? Buildings with the roof off, okay? Places that didn't provide air conditioning in hot weather, okay? Places that were, in some cases, uncomfortable to be there. Not all, but in some cases. My question is that what's the potential you think to integrate public libraries into your work? I didn't hear a word about it during any of the presentations.
So I'll start and appreciate that comment very much because you're right that when I talk about
it's got to show green.
So I think it's a really good point, and public libraries are, as a part of the outreach and Action Health, for example, we were partnering with 6 different community-based organizations, and they went to dozens of different places. I don't know for sure that they were in libraries. I wouldn't be surprised if they were, but you make a really good point, and for me to keep in mind in year 2 and beyond that about where to explicitly go, even if a community-based organization isn't going there to talk to people or to put flyers up, that it would be a good place for us as government to go to put information up. When I talk about the outreach efforts or the program, I usually mention churches and temples and places of worship, and I know that those were good places for us to go, but point well taken, and I think that we, or I can say at least my team personally, will take that into account as we move forward.
I also want to thank you so much for the suggestion, and it isn't a group that we've reached out to. I've made a note, and I plan to go back to San Diego and reach out to them directly. And I also just want to mention that our project is very much evolving all the time. We welcome feedback, suggestions, and definitely recommendations of new partners. So I'm very excited to take this back to my team. Thank you.
Yeah, I don't work directly with libraries in my work. I'm mostly in the community college, but that the omission doesn't mean adult ed has a very strong hold in the libraries. That's where Project Read, for example, was founded. I think it's also indicative of the way librarians think. They have to kind of be ahead of the curve on media literacy and the kinds of tools that are out there, which speaks to when you work with local communities, you really do have to map your network. Some communities in Northern California don't have a local library, they have a mobile library. So their library is a virtual world, whereas in the urban areas, the library is someplace you can actually walk into. So libraries, as the science of librarian, the career has to really stay ahead of that. But I think particularly in San Francisco and the Bay Area, librarians are health literacy intermediaries. The adult literacy world has already done some research that's about 15 years old now on literacy sponsorship, and that wasn't specific to health literacy at the time. Their institutional supports of supporting your literacy growth, like schools, and then their personal sources of literacy growth, like your best friend and your mother who wants you to go to school and get your GED. And then there's the intermediaries, and librarians are those. And so they can really straddle all those social institutions. Adult ed is already doing that. There's a lot of loss of funding that is traveling along with that as well.
This is not my expertise, but I just thought for those that are doing civic engagement and promoting voter registration, libraries would probably be a great partner to do that with, I would imagine.
Yes.
Umair Shah again, and thank you for the insightful presentations. Just a quick comment to my colleague here about the libraries. Harris County, we're on the public health side also working with our library side, and Edward Melton is actually from San Francisco, who's our new Harris County librarian, who's actually, we're trying to look at co-location and activities that really allow us to do some joint programming, so your point is well taken. What I wanted to ask the panel, and you all did a fantastic job of really setting out all the challenging issues in just a few minutes of time, is the real, it sounds like this force multiplying effect of really looking at community groups, partners, faith leaders, really doing our best in a time of constrained resources to really make more of that dollar go further with multiplying or spreading out or outreaching to other partners in the community. Can you describe how the context has potentially changed with this resource-constrained environment on the absolute critical importance of partnership and really working with diverse groups outside of ourselves in whatever field we're in, whether it's public health or healthcare, et cetera? Thank you.
So I'd be happy to start. I think that on our end, one of the things that we are doing in New York City is trying to integrate different programs and the messaging of those programs, whether those are health programs or programs that are not health related that are relevant to those who are immigrants or undocumented immigrants. And one of the examples that I started to talk about was the integration of IDNYC with the health program, but there are many more, including another program which under the Obama administration in New York City was providing free legal services to immigrants to sign up for deferred action, for the 2012 deferred action under President Obama, even when the 2014 deferred action was stopped in the courts. And so one of the things that we found is a very rich partnership in New York City, specifically between the Mayor's Office of Immigrant Affairs, which operates as a separate office, almost as an agency of its own, and the Health Department, and the Education Department, and the Social Services Department. And what we do is we try to more and more, particularly under this federal administration, align our messaging so that when you're getting the message out, whether that's through government or through a community-based organization, they're seeing us as unified. And that message may not just have a health angle to it. It may also have some education resources. It may also have some other social services resources with it. And the more I think about this, I think the more we're going to need to leverage that with the limited number of dollars that we're expected to see from government moving forward.
To answer your question, I think of it in terms of certain populations that we need to invest more resources to make a difference. And for example, the increasing number of adult learners who are entering our program with limited years of schooling. That is the fastest growing sector in the adult literacy population. Those learners need more customized time. They do not need to be in a class where there are learners who have been in school or have oral proficiency, which is greater than theirs. They will not get the individualized attention. Another population that I think is getting lost are the adolescents who have sort of maxed out of high school, but are still too young to go into the adult ed system because they're still children, and yet there's no room for them in high schools. There's years, what they need to do to gain all the academic college readiness, there's just not enough time. And so there are these populations that deserve more individualized attention and are going to need some innovation. There doesn't need to be a trade-off, though. I've just spoken to 4 different health literacy projects in the country. And they all have some sort of either funding from WIOA, the Workforce Investment Act, or they have it from, it's usually a health insurance foundation that decided to invest something in adult literacy professional development. And there was no trade-off. They did what they were supposed to do in the grant, and they just integrated the health component, and they still met their funding needs. So I don't think it has to be viewed as being squeezed out. It probably just requires a more thoughtful conversation about what you're doing with the resources you have. And that one last piece, when there is no investment in professional growth, you're relying on people to go back to whatever they learned in their BA to do their public health work or to do their adult ed work. And that's, if you think about the insurance system, you need retraining. To deal with the new diasporas in the U.S., you need retraining. And if that's getting squeezed out because you have to pay for direct services, that's where we're all in the trenches together trying to develop through volunteer efforts.
I'm old. Not old yet, but I've kind of watched recent years, not that I can see everything, but through the lens of these 10 sites and this network and our work with ASTO and also with NACHO, that public health, the reduction in dollars has made it more difficult for them to spend time on partnerships. I mean, I think it's a fairly resource-intensive activity. So we have felt really challenged, and I think the greatest successes in this work are these other larger faith-based health systems that have the faith commitments and have reached out to the faith community as sort of a kind of coming alongside public health, really. And then ACA policies around, community benefits came along, and some of these faith-based health systems that had these relationships really benefited from being able to do a lot of the community engagement parts of that policy. But I think it's been a real struggle because often that's the first part in many public health departments that are cut. That kind of outreach personnel or, coalition leadership and that kind of thing. That's what I've seen. It's a challenge.
Richie, let me build a little bit on what Mimi said and maybe expand it just a little bit further, particularly related to New York City and its surroundings. You mentioned rich partnerships in New York City as to align messaging with which I think is critical. We have a number of very large health systems in New York, Columbia, Mount Sinai, Northwell, just to name a few that impact, tens of millions of people. What's your experience with the large health systems involved in this? Because part of professionalism is to involve community facilities such as these large health systems. Matter of fact, as part of the Affordable Care Act, it is intrinsic that these not-for-profits, large health systems, be involved in this kind of work. What's your experience with that, particularly in New York?
So, to start, I think it's easier for government agencies to work, particularly in New York City. And this is, as a government official in New York City, I can say from the health department standpoint, it's easier for us to work with the public hospital system, which is a quasi, mayoral system, mayoral agency reporting into the mayor, even though they are a public corporation, than it is to work with private health systems. And some of the ones that you named are huge systems that go beyond New York City, go well into other areas of New York State. And it's certainly easier for us to coordinate as a health department and as city government in general with our health system. The program that I presented about started. The goal ultimately is to go to private hospitals as well. San Francisco, I believe, has done that. But we started with our public hospitals. So I will say from the outset that it's easier to do that. With that said, I think that on some issues where there is sort of alignment in terms of taking care, and this we have seen over the course of the last few months, particularly since the first travel ban was announced, I saw announcements from different health systems and different universities across the country, but particularly the ones I paid attention to were in New York, denouncing some of the language that's being used only because, from their perspective, even finances aside, they want to make sure that patients are not scared and should not be deterred from coming into their facility, whether that's a private hospital or a public hospital. And so one of the sort of upsides, if I can say that, about some of the recent toxic rhetoric is that it's bringing even these type of systems that don't normally work together together on the messaging. And we haven't done anything yet, but it's time that we're thinking about opportunities to align with them to get the message out that's consistent with public hospitals and government facilities.
I think that's an area that needs to be tapped a little bit more aggressively. So perhaps we can chat about that.
I don't know the ins and outs of the New York City Health Department. I know it's quite different than most other city health departments. And though I'm contradicting what I said before, but as long as I've been working in this field of public health linking with the faith community, they've always had a devoted staff person to working with the faith community, and they've pretty much taken that very seriously.
Any other questions? Yes. Lori.
Thanks for that, you guys. That was really good. Just one comment and then a question for Maricel. Is that okay? Or anybody also. But a comment is that as we think about limited resources and constrained resources and the effectiveness of medical care and improving health outcomes, or ineffectiveness, I should say, that we need, I think a lot of the work that we're talking about across the country is spreading resources, right? If it's going to keep going to healthcare, although that's unclear right now, how to incorporate community partners much more significantly than continue to focus on investments in medical care narrowly. So perhaps there's an opportunity. I know that in FQHCs that's happening. We just don't know how to do it well yet. So really trying to connect much better and medicalize poverty and actually reverse disparities. And sort of related to that, Maricel, you made the comment about the right to impose listening on others. I love that idea. Could you say a little more about that?
Yeah, first of all, it's not my words. That belongs to this wonderful language acquisition researcher. Her name is Bonnie Norton. She's from Canada, and she's an identity theorist. So she would, if she were in the room today, she would say, stop treating health literacy as a set of reading and writing skills. It's a change in identity. And by that she means when you gain new practices, new navigation skills, new competencies, you change who you're able to interact with. And so health literacy, the way I define it, is along metrics of social participation. And there's lots of theories and concepts and models that we can build on: community of participation, how someone moves from the periphery to the margins of even a single clinical encounter. You can see how change and talk. And that's why I think the adult ed classroom has to be seen in partnership with all the other clinical encounters, which have their own pressures. But at the same time, the adult ed classroom should not be viewed as this rehearsal place. You act like the expert in the adult ed classroom, and then you go and try it out. That's not the way this should be thought of. They are doing health literacy work in classrooms. It's just that it's on the exploration and it's the learning part that there's very little room for that in the 11-minute clinical encounter. And so I think that this, by shifting it from right to speak, you have to hold the floor, it really obligates the listener in a different way to think about what are the ways that we provide our least proficient community members to be leaders, to be recognized as such, and to share expertise.
Thank you. I have a comment and then a question. Ernestine, the Medical College of Wisconsin. The comment is to Rob. There is the library inclusion. I think how you get to library inclusion may not always be through the term of literacy we have in Milwaukee, where it's cradle to career opportunity through the school system, and the library system is very much, including that foundation, very much engaged. Whereas I know a parental engagement model in Tulsa, Oklahoma, as well as in Seattle, which focuses on engaged through early childhood education literacy and school readiness. They have a model that in Seattle, the public school system, the public library is involved. In Tulsa, Oklahoma, which we had the opportunity to try to bring that model into Milwaukee around parental engagement. And when we asked the same question you asked, why isn't the library involved? They tried to get the library involved, and it had more political fallout of why they didn't get involved. So I think it varies community by community, as you know. That's my comment. My question is probably to Justine and Rashid, and I appreciated your multi-pronged approach, Rashid, about what you're doing with Action Health. But as I was sitting thinking, and I wasn't clear, and with Justine too, with the emergency preparedness, from all of the reading, mental health and oral health is one of the most challenging. And New York, through the school system, is very much known for its mental health. I'm wondering if you would just speak to the challenge of mental health for this population as you've incorporated in the Action Health agenda, and also with your emergency preparedness. Justine.
So thanks for that question. And mental health and oral health are, great examples. Prescription drug coverage is another of the questions that we get most frequently about what is covered in this program. I didn't have time to go into the care coordination or the clinical model today, but in general, what we cover is what's covered at the public hospitals, at the federally qualified health centers. Right now, there are 7 FQHCs and 2 public hospitals that are in our pilot programs network. So that's for primary care. Somebody picks a primary care home. The suite of specialty care services that's covered is what's offered across the entire public hospital system. And that includes mental health services, in many cases, a huge initiative called Thrive NYC underway in New York City to improve the mental health of all New Yorkers. And so mental health is very much covered, sometimes considered in primary care, and sometimes, where it's not offered at your primary care home at specialty care. An interesting thing that I want to share with you that one of the leadership folks from one of the FQHCs shared with me recently was that there are people who actually are healthy or in their own perspectives don't need their annual physical or primary care. And they signed up for this program, and they're showing up to one of our FQHCs for just behavioral health services. They're showing up because that FQHC has behavioral health services. They like getting their care there. And when the physicians there ask them about their primary care visit, they say, no, thank you. We'll take the behavioral health visit. So a huge need and something that we recognize. Similarly, oral health services and dental is covered. And currently we have services on site at half of our primary care homes. And for those that you don't have it on site, you can go to another site.
Thank you for that very important question. And we do recognize the extreme importance of mental health, especially dealing with refugee and migrant communities who've, experienced long journeys, often trauma in their experiences in arriving here. All the trainings that we've put on to date, which is approximately 10 trainings, we've developed based on feedback from our community-based organizations on topics of interest. And mental health, surprisingly, hasn't come up until now. And once it came up, it became a huge discussion point. And we're actually dedicating the entire health piece to mental health for the refugee training that we're planning in May. So we have a special training. Most of our trainings are directly or are geared towards community-based agencies. The directors of these agencies kind of train the trainer model. But this special training we're going to hold in May. Actually, it might be moved to June because that's Refugee Health Month or Refugee Month. Anyway, we're going to have a whole piece focused on mental health, and we're connecting with different providers and different systems and trying to figure out what the actual content of the piece will be. But thank you. It's such an important piece.
I'm thinking about other forms of disability besides what we've just discussed, emotional events. What about disabilities like autism, for example? Let me just give you that for an example. Is that part and parcel of anybody's agenda, specifically in the pediatric population, early childhood development, where it's going to impact this population certainly, as well as the population in the United States in general?
I don't know if I can connect it directly with the project that I just presented on. However, overseeing our binational U.S.-Mexico border health program, where we have approximately 38% of our population in San Diego is Latino. We have a binational health week every October, which actually takes place over the entire month. It's put on by UC Berkeley Health Initiative of the Americas and all the Mexican consulates in the United States. And there's always a focus on autism in children and So it's something that's very important to the Latino immigrant community, I know, and we always receive requests on this topic, but not directly related, at least to my emergency preparedness and health communication project, but still something very important in the Latino immigrant community in San Diego.
I would just only add one thing. I think adult ed programs that are based in unified school districts, especially with the threat of deportations of families, many adult ed programs are helping families get their paperwork together around, so you can, if your child has an IEP and the child has to leave the country, that there's a history, that there's a record of what's going on. So there's just a navigation piece that is starting to kick in. But that is I only know about that when the adult ed program is based in an elementary school district.
And also, I just want to add one thing. The way I didn't really go into this because I got a little overwhelmed with having 15 minutes and trying to share everything quickly. But the way our partner relay works is we share information during emergencies. However, when there isn't an emergency, we still share helpful resources with the community. And we've shared a lot of resources around mental health. And autism and other learning disabilities and developmental disabilities is something we have not pushed out to our network, but we will do that. And I also mentioned towards the end that our communication platform didn't work very well, and we're exploring new platforms. However, we're still communicating with our relay, and we're doing that just through old-fashioned email right now, but we're not slowing down. We continue to share information.
Just one thing to piggyback, because when I work with adult ed teachers, we start to think of all these public health content areas like diabetes prevention, gestational diabetes prevention. I'm working with a program right now that's our thematic focus, but they don't really want to talk about gestational diabetes, even though they're marginally interested in it. They want to talk about peer coaching and how you can become a better peer coach in that context. So I think, again, another opportunity to think with people who think about pedagogy, because teachers are not doctors, they're not health experts. And just one quick example, I knew about a school that the school and the parents and the teachers, everybody was worried about gang violence. And they wanted that to be the thematic issue of the curriculum within the schools. And it was so hit you over the head with something that it scared people and it shut down conversations, and it definitely didn't engage the adolescents. So the adult ESL teachers said, you know what, we're gonna do our opening unit on names. What's your Facebook name? What's your social media name? What's your avatar name? And what does that mean about who you're connected to? And so the opening unit in the ESL class was about belonging and how do you mark belonging. They did get to talking about why some belongings are harmful and hurtful. But I think it's that kind of thinking that happens when teachers get together, because they're looking for the universal. They're looking for the on-ramp, the human on-ramp that makes learners want to talk to each other. And I think it's just a great example where it may not be diabetes. It may be self-care. It doesn't have to be gang violence. It can start with names.
I'm looping back around to the mental health question because I just thought of something. Is that the sites, in particular, my little national sample, the ones that serve immigrant communities have in the last couple of years asked for suicide prevention education from their healthcare resources, and many of them have then, as a result, also used the training in mental health first aid. So there's been a real interest in the faith community partners in learning more about that, which is a really good thing, I think, for them to have more education and training around that topic area.
Hi, this is Julia Ackley, and I'm with Sutter Health. I'm the Health Literacy Program Manager, and I was just going to respond to your question about autism. In a previous role, I worked for Help Me Grow, which is a national network, and it is a program that does care coordination for children with developmental delays, including autism and behavioral challenges, so 0 through 5. And they do an extraordinary work about partnering with pediatricians, and they have a health literate, multilingual, trauma-informed care approach about supporting families, and families serve as advisory members and on boards. And so that's just something to keep in mind, that this work is really happening. And a lot of when I worked in Alameda County and in Oakland and Hayward, and a lot of the people we worked with were immigrant populations, and it was supporting those populations. I think one of the challenges is that behavioral health care programs are limited, and there's usually a long waiting line. And if you're trying to get into Children's Oakland Hospital, you could be waiting 3 months before you even get services for speech or autism. So there's just a real lack of services out there, and that's sort of where the budget is tightening. And then I think I was just going to ask a question. As a person from a large healthcare organization in California, so I'm so interested in partnering and learning more about that. And I think I wanted to ask the panel and Mary Sell in particular about how we do partner with adult ed, and how would you suggest that we sort of start these partnerships and incorporate it into the work that we do? Thank you.
There's a lot online in terms of directory. You could Google map, the areas where you work in and find your local adult ed. But there's usually, every state has usually some sort of entity, so it's just figuring, what state did you say you were in? Oh, so you would go to this organization called OTAN. It has like the biggest telephone book of all the programs, and you can search by zip code. And that's typically the way we find programs too, and how sometimes learners find programs. But there's also, this exactly is the communication problem we all need to solve, because it usually takes a person, usually an academic at a university, who can be the community partner. If you are near a university, go find your Institute of Civic and Community Engagement, because those folks have the infrastructure to bridge build for you, and that might relieve some of the pressure, that a lot of the administrative pressure if you don't have an extra staff person. Most universities have some sort of service learning component that their students need to go out into the community and do service work. So there you have a cadre of individuals who are in training who might be able to work for you. I've seen that happen in Philadelphia with nurses and TESOL practitioners over an extended period of time working with elderly immigrants. So sometimes it takes a university. If you're in Northern California, you're lucky. I think between our two universities, you've got a very large network to dip your toes into. My program is the oldest adult ESL teacher training program in the United States, so we also have an extensive network. If you're not that lucky, you're in rural areas, just come talk to me. There are a lot of ways to connect, at least virtually, with the right practitioner. And then from there, the work is very local, trying to figure out who that local network is that has extra funding, that has an interest, that has a hotbed issue. That's how I found out about lead poisoning in Salinas. Just talking to the adult ESL teachers, what kind of questions were your adult students bringing into class at night? It was usually they had seen a flyer, they didn't understand it, and they were scared. So that's the problem. We also don't have a communication portal to be able to crowdsource our ideas and share it. So I think if we can figure out that problem, it'd be a great test case for other areas of the country.
Anybody else in the panel? I have time for one more question.
Hi, I'm Kim Parson. I'm a member of the Roundtable, and I'm actually asking this question for another member of the Roundtable who couldn't be with us because of weather. It's Wilma Alvarado Little. And so she'd like to follow up on Bernie's question. What considerations have been made for the deaf and hard of hearing communities, especially those who ASL is not their primary or preferred language?
Well, you can be sure I'm going to grade you on that one.
Good thing she's not here to hear the answer, right?
Wilma always.
I can sort of answer that question. So I represent our public health department, and the project I presented on with the communication relay is in partnership with our Office of Emergency Services. And I'm not going to use the right terminology, but I know that our alert warning system is has some type of technology in place for the hearing and visual impaired. And I don't know what exactly it does, but I can get more information on that. But I do know that that has been something taken into consideration, and we do have a way of getting the message out for the visually and hearing impaired. Sorry, can't really expand on that.
But we will follow up on that question. Well, thank you all very much. We have time for a 15-minute break, and we should be back again at 3:30 and resume the afternoon. Thanks once again for an enjoyable panel.